view.
Total view. So, this one, first you explained that I'm gonna have my hands towards the front of your neck. I'm not gonna be choking you. This one I do get consent for, because it is their first time, they don't realize what you're doing. You need to work your fingers on the front of the transverse processes, not like this, because that will hurt even more than the already uncomfortableness that this is. So maybe I'll wiggle in that way, but then we want to try to get the whole finger on the tops of the TPs. This is commonly used for flexion, which is common down at C5, because C5 translates forward into extension, you get nerve symptoms. So this helps to push C5 backwards to posterior translation to get the vertebrae off of the nerve. So that's a common mechanism or use for this. Doesn't mean it can't be used the same way elsewhere, that's just where it's most common. That's it. So we have to worry about the carotid, we have to worry about the SCM. So the easiest way to try to get in is going to the TPs behind the SCM, stay on the TPs, and slide your hands up front onto the hard things. If you come down from the SCM down, you'll be on the carotid. So if you go to the TPs and just stay along the wall all the way to the front, you'll be able to get under the carotid and under the SCM, and then you just have to wiggle the muscles out of the way to get to the front of the TPs. Then that stays there, don't let it move. Because then I always give it a second too to make sure I don't have a pulse. Good. And you can see that, well, Sam can't see this, but he'll appreciate the video. You can't see my fingers really because they're on the front of his neck, but underneath stuff. So they're really in there. But it should be a flat grip. If you do fingertips, they're not gonna like it. So with this, once you're flat, I should have you do this. Can you increase the table height for me? That's good. Good. So when we're here, we can just do a bilateral A to P, which is like a CPA, except I'm not in the center. Just doing a bilateral UPA, which is a PA, A to P.
Just about the same time.
Yep. That way it's a bilateral technique, because usually we have, you may have bilateral symptoms, C5, C6, and then if you want to, it's a tricky area to put your hand in, put your hand out, so I'll usually be here anyway like this, but I'll just, let's say he only has a right-sided problem that I want to deal with, I'll just keep my hands here just so I can feel the movement, don't block the movement, and then I will do the right side only, and that would be your A to P UAP, unilateral A to P. So bilaterals, just straight down. Use your body so that you don't kill their neck, and then A to P straight down for the one-sided technique.
The one side, it's not for rotation, it's just to relocate that one side.
Yeah, you're not commonly, usually this is for nerves that you're doing this and for translation. So conceptually, I guess you could work out rotation in your head, but that's not what it's meant for.
Are you still going at the 45-degree angle?
This I'm pushing straight down, because it's really, in reality, for a posterior translation. And it's not extremely specific, I'm not just on one segment, I am pushing multiple, because if you get on one segment, it's not like it's not allowed, but it's not gonna feel good.
How does it feel, Sam?
Fine.
So you're pushing the whole thumb, not
I'm
just...
trying to stay on I'll put pressure on specific points, but I'm trying to be as broad as possible, because it's a very sensitive area.
When would you use this opposed to like the inferior?
So this is for posterior translation, or technically I guess it is similar for flexion, but this is mostly used for flexion when it involves nerves.
Okay.
That's one. So if somebody comes in with cervical radiculopathy, this is a common one one of the common techniques I'll use to clear up that space. Because they usually have radiculopathy because of the anterior translation, so we'll push it posteriorly. And then when it's posterior, then I'll work on, your typical posterior glides where it's, whatever is flexion or extension. Good. And then side glides is a similar concept. You are taking the articular pillar with your thruster knuckle once again, and you are pushing it which way? Sideways. So that's all it is. So it's not necessarily direction specific. It is used to once again clear, bless you, clear the neurological structures. So this technique is often combined with nerve glides. So you can do it as a straight technique, or you can combine it with a nerve glide if you have a partner or if you want the person to actively do a technique. So if I do a left side glide, it would be to loosen up his right joint. So he would do any type of nerve techniques on his right side. So first, just the technique. Give her a little bit of compression. We get onto the articular pillar. Good. And then we just rest our hand in place. My elbow is facing this way because that's going to be the direct force. And then all it is just, I'm just holding his head with my left hand and with my belly, and my right hand is going left. My thumb is not doing anything other than resting.
You using that knuckle thing you meant? The
Thruster
buster?
knuckle, yep. Radial side MCP, knuckle buster, sure.
That's a segment specific.
This one is segment specific. Just skin locking to get,
Yeah, that's not the actual technique.
well, I'm skin locking to get on it, and then that's the technique.
Okay.
Then I'm moving down, skin lock to get on it, technique. Skin lock to get on it, technique. I would stay there for more than 3 seconds. I'm just giving you an idea of how you move. I would hang out 30 seconds, reassess. I only treat my right hand. I believe that.
Only left-sided trees.
Straight to the right. Skin lock. Straight to the right. Skin lock.
So the skin lock, you're putting it on slack? The skin?
I'm getting under the skin. Because if I just go like this is just going to be pushing skin. So you need to swoop the skin out of the way so that your MCP is right on the articular pillar. Relax.
And how do you know, it's gonna sound dumb, how do you know whether you're on articular pillar or TP? It's not gonna be hard to feel that far.
No. Yeah. So so when I start my skin lock, I'm on SP roughly, and I just swoop into the crevice. And if you keep going, let's say, oh, am I in the right spot? Keep going, you're gonna hit a big bump on the outside that's very tender. That's TP. Technically, you can go the same way, TP and go in, but that's a little bit trickier. It's easier to swoop the skin from underneath. Get into that little crevice. You could even feel it over your fingers. And then push. And then your grades are the same. If we wanted to combine it with a nerve glide, what I'm gonna have you do is you're gonna be here, and I want you to bring your elbows straight and bend your wrists like that, and then go like that, and just hold it for 2 seconds each way. So we get onto the appropriate segment. Relax the head for 1 second. All right, now you can tense up if you want. Good, and go ahead. And you can either hold it, clickety click, 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 and you can mobilize. That's how you combine.
And are you pulsating the whole time while he's doing that?
Yeah. You got some tension there, in your neck.
feel like a snapping in my ulnar.
Yeah, well, it's not, over there. I'm feeling the vibration. Is it down there? I thought it was coming from up here.
See the snapping
Is that your thing, Beth?